Welcome to the Lympho-vascular Terrain series. This is part 1, Introduction to the Lympho-vascular Terrain. My name is Ivan Dubin. I'm an osteopathic practitioner based out of Vancouver, Canada. I hope you enjoy this presentation. As always, I'll begin with the disclaimer. The following presentation is not to be considered medical advice. It makes no claims of diagnosis of disease. The topic is intended for the consideration of manual therapists and is not an endeavor to practice medicine. Furthermore, the presenter is not a medical doctor. If you are concerned about your current medical status, you should consult a physician for medical advice. A quick educational note. This presentation is a general introduction to the lymphovascular terrain. The intention is to provide a view on lymphokinesis and overall resiliency for anyone interested in the study of lymphatics from an osteopathic perspective. This introduction is the first in a series focusing on the lymphovascular terrain. Part 2 will be the lymphovascular terrain and the dynamics of health. Part 3 will be cranial and cervical lymphovascular terrain. Part 4 will be mediastinal lymphovascular terrain. And Part 5 will be liver lymphovascular terrain. Still to come will be parts detailing the stomach, the epigastric lymphatics, the small intestine lymphatics, the urogenital lymphatics, and finally the lymphatics of the extremities. Presentation overview. I will discuss the role of the lymphovascular terrain in contributing to the management of homeostasis. I will describe some basic anatomy of the superficial and deeper lymphovascular terrain, including the interstitial tissue, fascia, and connective tissues. I will explore the organs, lymphatic structures, and pressure gradient dynamics that contribute to lymphokinesis, detoxification, and homeostasis. I will discuss how lymphovascular terrain dysfunction can result in the breakdown of detoxification pathways and an increase of hidden inflammation. I will explore how hidden inflammation is present in most chronic health complaints or any chronic condition that ends with the phrase itis. This includes bronchitis, laryngitis, otitis, pericarditis, gastritis, pancreatitis, interstitial cystitis, prostatitis, arthritis, and other chronic issues such as IBS or gout, lower extremity edema with swollen ankles, and even perceived weight gain as the body holds on to fluids in the arms, the face, and around the breasts. What is lymphovascular terrain? The lymphovascular terrain can be viewed as a living bioplasm contained within a connective tissue matrix containing mostly fluids along with a community of cells and bacteria. Using the lymphovascular terrain as a frame of reference is designed to create a three-dimensional perspective of the human body for the practitioner. The terrain is the result of interrelationships of the lymphatic structures, the microbiome, all connective tissues, mucosal barriers, the central nervous system, and all vascular structures coexisting in one pressurized ecosystem. Ultimately, the result is a living metabolic sponge of varying tissue densities, fluid concentration gradients, tissue pressure gradients, along with electromagnetic properties and tensegrity properties. There's a clear pattern of oxygenation and detoxification expressing itself in the cycles of homeostasis. I believe it's more or less a yin and yang principle with two parts contributing to a whole, meaning that the health and resiliency is the result of the balance between two dynamics working in opposition toward a common goal. The lymphovascular terrain is the space where all the machinations of the detoxification pathways strive to fulfill their goals. There is a cycle required for health, and any tissue resistance in the body will limit the blood flow, thus constricting the expression of the detox pathways. Decreased performance of the detox pathways will lead to congestion, inflammation, and eventual cellular degeneration. The image of the human tissues and the sponge can be seen in the design of the bone. Both the osteon of compact bone and the softer trabeculae take on similar form, differentiated by their respective roles. This is an image of some interstitial tissue. This frame of reference presents a different shape to the sponge, but the architecture remains identical in its role as a container or facilitator of the expression of life. Clearly, our bodies are meant to be adaptable, but yet must contain a range of supporting structures and barriers to allow for the ideal exchange of oxygen in and carbon out. Nonetheless, what we as manual therapists interact with under our hands has a sponge-like quality. Most importantly, the detoxification pathways have a clearly defined movement within the metabolic sponge that is committed to removing toxic proteins and other compounds from all tissues, ensuring the optimal composition of the blood. Lymphatics and homeostasis. The lympho-vascular terrain manages many physiological parameters required for optimal homeostasis. For example, we have the protein concentration in the interstitial fluid, the volume of extracellular fluid in the body, and the pressure of the interstitial tissues. Lymphokinesis allows for protein molecules to help circulate other smaller molecules as they adhere to the proteins for active transport through to various cells. Cytokines are hormone-like proteins that are produced by leukocytes and various other cells, and they become part of the lymph protein load if they are left over. The role of the lymphovascular terrain in managing hidden inflammation is a critical component of avoiding tissue degeneration. It's worth noting that the idea of the lymphatics moving suboptimally, we look at that as a stasis, so it's defined as a lymphostasis. Now, this doesn't just occur in the interstitium. You can have lymphostasis in the brain, affecting the eyes, obviously the heart, the lungs, the liver, the kidneys, the intestines, the testes. You can have lymphostasis in body cavities, influencing bone at the level of the periosteum, lymphostasis inside ligaments, lymphostasis around tendons. For tendons, it's a form of a tendinitis. You can have lymphostasis around joints, around nerves. Lymph nodes can be compromised and create lymphostasis. Same with the lymphatic vessels, and obviously the diameter of blood vessels can also affect the exchange of lymphatics in the interstitium itself. You have the establishment of lymphostasis for long enough, it will become chronic and inevitably turn into some type of an itis. There's many diseases that end in an itis, such as appendicitis, carditis, hepatitis, meningitis, otitis media, cystitis, iritis, bronchitis, arthritis, sinusitis, gastritis, pancreatitis, diverticulitis. The medical suffix for infection is known as an itis, and also used to indicate inflammation of the tissue. For example, otitis media means ear infection with inflammation of the ear structure. So that's a good indicator that once a person's health trends into the domain of having itises, then it's a good place to look for that is the potential of lymphostasis that's occurring, quite frankly, locally, regionally, and maybe even globally, even though it might just be a specific area that currently has the itis. Osteopathic view of homeostasis. Homeostasis has been described as a motion towards stability and uniformity within the various normal body states. The stability is characterized as a dynamic stability, as it is constantly oscillating between specifically well-defined limit set points of activity. Health is defined, therefore, as being an adequate state of adaptation compensation, and dynamic equilibrium. This is necessary not only within the environment, but also within the organism itself. That comes from osteopath Dummer. Aspects of homeostasis include arterial blood, baroreflex pressure homeostasis, core body temperature homeostasis, volume of body water homeostasis, blood glucose regulation homeostasis, potassium, sodium, calcium homeostasis, pH of extracellular fluids, oxygen and carbon dioxide homeostasis, plasma pH, and cerebral spinal fluid pH. Some of the mechanics of homeostasis: thermoreceptors, mechanoreceptors in the connective tissue, respiratory control center, the renin-angiotensin system, cellular nuclear receptors affecting gene expression, otherwise known as epigenetics, osmolarity lymphatic system, stretch receptors in the aortic arch, carotid sinuses, and the internal carotid arteries, neurotransmitters in the central nervous system, and neuroendocrine physiology via the hypothalamus. All the examples of the various mechanics of homeostasis can be influenced via manual therapy. But let's begin now by looking at one aspect of the lymphovascular terrain, most recently categorized as an organ in the body, which is the interstitial tissues. Here we have a diagram of one example of interstitium. We can view the dermis and epidermal layers, as well as a subdermal space described as interstitial tissues. If I highlight the area here of the interstitial tissues, what we'll notice is that we have lymphatic structures, anchoring filaments, blood capillary, we have veins, all of them interacting in a structure of tensegrity and fluidic pressure. Here we have another example of interstitium. Again, it's located below the mucosal layer. So this whole structure here is considered interstitium. Now this doesn't include any of the lymphatic components specifically, but it's just meant to give the viewer a sense of the sponge-like quality. Interstitium defined according to the Oxford Dictionary: it is a supporting or connective tissue or material that lies between the principal cells of an organ or between structures in the body. It is a network of collagen fibers and fluid-filled spaces that underlies the skin and surrounds the gut, muscles, and blood vessels. It is found throughout the body, just below the skin, and it envelops the deeper digestive, respiratory, and urinary systems, and it has also recently been classified as an organ. Continuing to define the interstitium, the non-vascular spaces, known as interstitium, are not empty spaces, as they are filled with fluid that can transfer particles without the use of cells, such as macrophages. There is a broad and interconnected network of interstitial fluid-filled channels throughout the body, including the structural coverings of nerves and vessels. There is a continuity of the interstitial fluid called hyaluronic acid that is found in all areas of the body except intracranially, regardless of the stage of development. For instance, the tissue allows for particles to travel from the colon or the skin or from the colon to the liver. It has also been shown that tumor cells can migrate with the help of the interstitial dynamics. Spaces that are in and around structures, including arteries, veins, nerves, and ducts that pass through multiple tissues and organs, could serve as conduits for interstitial fluid transportation. This includes the ureters, the urethra, the epididymis, the fallopian tubes, and the salivary gland exocrine ducts. Here we have another example of the architecture of the interstitial tissues, reestablishing the sponge-like characteristics. Moving on from here, let's look more closely at how it plays a role within the lymphovascular terrain. This image exemplifies the blending of all aspects of the lymphovascular terrain, of course without the nerves and associated mucosa, also known as mucosal associated lymphoid tissue, or MALT for short. So we're just looking at the interaction here with the tissue cells, the lymphatic capillaries, venules, and the lymphatic ducts. And this image is a great way to look at the environment as a matrix. This image represents the lymphovascular terrain in a more classical sense. Also does not contain the mucosal associated lymphoid tissue, but it does show the layers beneath the skin and the intermingling of blood and lymph vessels. From here on, we want to talk a little bit about the pressure gradients that would have an impact on this tissue and all tissues in the body. Talking about the pressure gradient environment that all tissues are exposed to, the human organism relies on optimal pressure gradients between tissues, arteries, veins, lymphatic structures, and organs in order to sustain homeostasis. This is an example of structure governing function. The simplest expression of this is blood pressure. The pressure inside the lymph capillary is about 1 millimeter of mercury at rest, and the flap valves are closed. Lymphokinesis is reliant on optimal tissue pressure. Tissue resistance and pressure result in an accumulation of lymph and toxicity, and tissues will react to toxicity. Tensegrity, metabolic fluid concentration gradients, and electromagnetic dynamics are reflected in the state of the tissues. The management of blood pressure is a systemic activity in which not just the heart, lungs, liver, kidneys, etc. play their role in homeostatic blood pressure, but also the connective tissues do their job with an organizing principle of contraction and compression. The role of the pressurized environment. The human body is essentially a metabolic sponge of varying densities with fluidic concentration gradients, tissue pressure gradients, connective tissue tensegrity, and ideally optimal microbiome diversity. The role of pressure gradients is to facilitate the expression of health in all tissues. Optimal lymphokinesis requires that tissues reflect ideal pressure gradients and chemical gradients, since they surround the vascular structures and act like a three-dimensional sponge. The reality of the pressurized system coincides with the rule of the artery, in that the arteries also require ideal pressure in surrounding tissues to deliver blood optimally. Any restriction in blood flow will inevitably affect the lymphokinesis around the respective artery or organ. Connective tissues organize on behalf of the artery. Connective tissues develop prior to arterial structures in the form of a lattice or support structure. This is an embryological distinction. The arterial system needs the support of the connective tissues to act on its behalf in order for the blood flow to succeed. Decades of research indicates that the connective tissue system has inherent intelligence and communication qualities. I surmise that the intelligence of the connective tissue network organizes itself around the vascular components in the form of pressure in order to sustain blood flow. In regards to fascia and Dr. Still, this is coming from biographer Lewis in 2016, who wrote From the Dry Bone to the Living Man. Dr. Still suspected that the fascia was itself a likely matrix that held within it the power to either support life or death. Dr. Still also had an interesting take on the process of health when he insisted that unimpeded arterial flow is essential to maintaining the venous and lymphatic flow. Critical in the health process is ensuring that the body can remove dead substances before the process of fermentation in the lymphatic and cellular system. This fermentation occurs when there is some type of blood confusion that is a result of poor circulation and stasis, leaving a terrain that is ripe for fermentation. Regarding connective tissue, approximately 16% of the body's weight is made of connective tissue, and it also contains 25% of the body's total water mass. It forms the biological building block of the muscles, skin, nerve sheaths, ligaments, tendons, fascia, blood vessels, and blood, joint capsules, aponeurosis, periosteum, bones, adipose tissue, and cartilage. Quote from Seffinger, "Generally, the body's tissues are under some degree of load and extension or expansion." Another Seffinger quote, "In systemic disease, alterations in extracellular fluid and electrical potentials cause changes in the biomechanical integrity of the fascia. Areas of acute and chronic congestion, swelling, laxity, stiffness, and pain are produced." Regarding connective tissue, with the focus placed on the fascial component, we also acknowledge the ability for the tissue to deform accordingly. Homeostasis in the body can be supported by mobilizing the parts of the connective tissue called the fascia with its related characteristics. Fascia and bone both deform in specific various ways. According to Wolff's law, bone will form around the lines of stress, and the same applies to connective tissue and fascia. The body is composed of sheets of fascia, which are formed by fascia that fuses together surrounding every cell in the body. Ligaments and tendons are formed from the fusion of various layers of connective tissue. Even the smallest muscle fibers are surrounded by thin layers of fascia. The layers can be viewed as a plastic bag inside a plastic bag inside of another plastic bag. Connective tissue research. It has been determined that all the white collagenous membranes and envelopes in the body contribute to an interconnected fibrous network. The overall total surface area of fascia in the body includes membranous pockets and millions of endomysial sacs that by far exceed the surface area of any other tissue. It is important to add that fascia contains 10 times the amount of sensory nerve receptors than the muscle tissue muscle spindles. Additionally, there are also several different types of sensory receptors, such as the mostly myelinated proprioceptive Golgi, Ruffini, and Puccini endings. There are also numerous small unmyelinated free nerve endings that are found in the visceral connective tissue and the periosteum. Connective tissue embryology. Embryologically speaking, the vascular and lymphatic vessels originate within the connective tissue layer. Connective tissue is highly vascularized. Connective tissue divides, surrounds, and guards almost all structures in the body. It acts as a transportation highway for nutrients and helps insulate the body by storing fat. The connective tissue is capable of combating pathogens and of generating a microelectrical current within the ground substance. The structure of the tissue is made of a ground substance called the extracellular matrix and fibrous cells. That again is coming from Bruno Schichli. A big part of embryology is the presence of limiting tissues, which are represented in the form of connective tissues. According to Blechschmidt, we know today that all functions, even those of the sense organs, are initiated by growth functions, i.e., basic functions at the time of their formation, and that the so-called specific organ function only gradually develops on this foundation. According to Blechschmidt, the embryological and morphological origins of the limiting tissues differentiate from the inner tissues around the third week. With the help of biodynamic forces and metabolic fields, the growth of the human proceeds with the limiting tissues acting as guidance for the developmental features of life to unfold. Like all formations, blood vessels must first have a pre-development or prerequisite before they can make their appearance. Once this occurs, there must then be adequate space at the proper moment in time, i.e., the immediate kinetic occasion. This speaks to the idea that the connective tissue system is working on behalf of the blood flow, since it appears before the blood flow and vascular system embryologically. Coming back to this image of lymphovascular terrain, it's important to consider that this dynamic where we have proteins leaving the arterial system, traveling into the interstitium, then being picked up by the lymphatic system and the venous system. This entire process is dependent on ideal pressure gradients and tensegrity. Any alterations in those dynamics is going to have a profound impact on this process. This includes the process of osmosis and diffusion that's associated with the detoxification aspects of toxic proteins leaving the arteries to be picked up by lymph and venous flow. From an osteopathic perspective, the interrelationship between structure, function, and form are represented in the organization, exchange, and origin of the tissues. Hence, it is important that the osteopathic practitioner remember that the principles of osteopathy come from the principles of life. The magic of life lies in the fact that tissues involved in a successive stage of embryological development or form and structure contain the embodiment of a plan that precedes their arrival. All of this being modulated by a persistent interference between the epigenetic factors and the morphogenic fields. Some clinical implications. In addition to recognizing osteopathic lesion classification, we can view the tissues as organizing themselves respective to sustaining blood flow, meaning that joint dysfunction that produces symptoms is not just isolated to the joint itself, but also includes the surrounding tissues. For example, we can view tissues or muscular guarding as a means to stabilize blood flow and limit further tissue damage with excessive movement. It's not just the central nervous system that promotes tissue guarding, as the connective tissue intelligence organizes to support blood flow first, as is the case via embryological expression. What we as practitioners have under our hands when contacting the human form is a pressurized environment of various tissues whose sole goal is the maintenance of homeostasis. This allows for optimal osmosis, diffusion, and other chemical gradient expressions of metabolism, as the body oscillates between nourishing tissues and detoxification. This cycle prevails until the resistance to flow within the tissues and vascular structures acts as a limiting force. Talking about entropy versus homeostasis, in the absence of homeostasis, we have entropy. Once we accept that tissue resistance can occur in any part of the body, including within the organs themselves, we can set our gaze towards visualizing the lymphovascular terrain in its entirety. Once we can see the terrain and its physiological nature, we can devise a protocol that's designed to liberate tissues, organs, etc., and help the body restore lymphokinesis. The mechanism of homeostasis is to dampen entropy. Entropy results in the absence of optimal blood flow. Toxicity increases in the absence of optimal blood flow. Pressure gradient dysfunction are an indicator of potential entropy. The terrain that embodies the pressure gradient dynamics is the lymphovascular terrain and all of its components. What we palpate in the lymphovascular terrain is a pressurized metabolic sponge of various fluidic concentration gradients, tissue gradients, tensegrity dynamics, and electromagnetic phenomena. Now that I've discussed the pressure gradient environment of the living bioplasm of tissues, as well as the importance of understanding the structure-governed functions paradigm, and that it's a key mechanism of homeostasis, we can start to move into the anatomy of the lymphovascular terrain. The best way to visualize the lymphovascular train is to start with understanding the presence of the vascular tree. That means arterial and venous. Then you can overlap the lymphatic components over top of the tree like a grapevine wrapping around the trunks and branches of a tree. The lymph nodes themselves are like the leaves of the vines. This includes the transition of lymph to and from organs through the interstitial tissues and connective tissues. You can also include the mucosal barriers found in tubular structures accompanied by bacteria or microbiome and its relationship with the epithelial cells. Some basic principles of the vascular tree are that the blood flow leaves the heart, travels from the center to the periphery of the legs and the arms and up into the cranium on both sides. The venous blood makes its way back from the periphery towards the center from the entire body, including the cranium. Basic vascular tree mechanics. We need to consider the diaphragm, which is a type of a pump, muscular pump, that divides the upper and lower extremities into pressure gradients. Above the diaphragm, we have a negative pressure gradient, which allows for a negative pressure in the mediastinum to help draw back venous blood and lymph back to the center of the body into the venous angles. Below the diaphragm, we have positive pressure. That creates an automatic resistance below the diaphragm to lymphatic flow coming back. Now the lymphatic flow starts at the periphery, moves its way back into the abdomen on both sides, as far as lower extremities. I'm going to go over detail of all the deep lymphatic systems of the abdomen and pelvis and legs. But for now, this is just general description. Below the diaphragm, there's the thoracic duct, which travels deep alongside the vena cava, eventually connecting with both left and right venous angles. The lymph has to come up and pass through the positive pressure gradients under the diaphragm to be drawn in to the negative pressure gradient environment of the venous angles. The same is true for the lymph leaving the deep lymph nodes of the cervical spine and the lymphatic system components that are being supported by the cervical lymphatic system. It's important to remember that in general, the lymphatic system is divided into two sections. The right side of the head and the right arm drain in the right venous angle. The left side of the head and neck, left arm, and both legs and abdomen drain on the left venous angle. This is very general, but is a fact. Another important distinction around the lymphatics is that typically the lymphatic vessels and nodes follow back accompanying the arteries and the veins. There are twice as many lymphatic structures, capillaries, that surround the venous system as there are the arterial system. So the lymph tends to wrap around almost like a vine around a tree in many aspects through the body, including in the pelvic area with the aorta coming down into the common iliac arteries. Now, the flow of lymph is, even though it is nearby arteries and wrapping around arteries and trailing alongside them, that lymph has to travel back against resistance. So when I talked about the metabolic sponge of the body, Tissue resistance will limit the direction of the lymph flowing back towards its final destination, in this case the venous angles. But that's likely not the only place that the lymph is being processed, and I'll explain that in a little more detail as I progress. Additionally, any type of issues around the cranial base, cervical spine, or even involving the carotid arteries will increase tissue pressure, thereby limiting the flow of lymph from the cranium back down towards the respective venous angles. So that's an intracranial pressure dynamic as well that will affect the lymphatic system. I talk a lot more about that in the cranial and cervical lymphatic presentation, but I'll touch upon it a little bit more in this one. Just an image to show you what I meant by the vines and leaves acting as a lymphatic system moving around the tree trunk, which I describe as the vascular system. So let's talk about the role of the lymphatics. The lymphatic system can be seen as the integrator of all bodily fluids and as the second circulatory system. If the lymphatic system would cease to function, the result would be massive edema, retention of toxic metabolic wastes, and death within 24 hours of onset. Osteopathic literature denotes it as a, quote, secondary circulatory system. Your lymphatic system is a network of organs, vessels, and tissues that work together to move a colorless, watery fluid known as lymph back into your circulatory system, known as your bloodstream. As a vital part of your immune system, your lymphatic system protects you from infection and destroys old or abnormal cells your body doesn't need. Lymphatic system functions also include maintaining normal fluid levels in your body and absorbing fats and fat-soluble vitamins so they can make their way into your bloodstream. Talking about the movement of lymph, also known as lymphokinesis, the lymphatic system runs parallel to the arterial and venous system. The characteristics of the lymphatic system are as follows. Along the way, the path of the collectors are interrupted by intervening lymph nodes. The flow of collector trunks goes into the venous system. The terminal site is a confluence situated at the left and right venous angles. And as I mentioned, the direction of lymph flow is mostly always moving against the flow of blood within the arterial system. The arterial flow moves blood from the center to the periphery, and the lymph and venous system move from the periphery to the center. This entire process is reliant on optimal tissue pressure and a limited resistance to flow. This is a typical representation of the lymphatic system. Not easy to distinguish the deeper lymphatics from the superficial lymphatics. But again, just to reiterate that it is divided into two sections, whereby the left half of the cranium, both legs, and the left arm drain at the left venous angle. The right side of the cranium and the right arm drain at the right venous angle. We want to remember that we also have the presence of that diaphragm, creating the negative pressure above the diaphragm, positive pressure below the diaphragm. And of course we have the presence, this lymphatic system should be overlaid on top of the vascular tree. We have the heart here, aorta, and the flow going all the way from the extremities in all directions. Hence the image of the tree. And in addition, we have the lymphatic, the venous flow coming back against the grain from all areas to coalesce again here near the heart. We have an image here That's giving you an idea of the collection of lymph nodes around the venous angles on both sides. Not a good distinction around which are deep and which are superficial. But here in the abdomen around the aorta, we can clearly see that all of these lymph nodes are going to be deep lymph nodes, and they trail along the vena cava and the aorta, including the celiac plexus, also extending down into the pelvis and into the legs. As I progress along, I'll elaborate more on the existence of the deep and superficial lymphatic systems. Let's go back to lymphokinesis. The superficial subcutaneous lymphatic system drains the subcutis and the skin. The deep system conducts the lymph from the joints, muscles, tendons, sheaths, and nerves, as well as the bone. There are also deep collectors that follow with the arteries, and many are enclosed alongside the arteries, alongside the veins, all within a supportive vascular sheath. And that vascular sheath is connective tissue and is a type of a fascia. The deep and superficial systems are interconnected via the perforating vessels, connecting the two systems together. Principally, the lymph perforating vessels transport lymph from the deep to the superficial parts of the body. The organ lymph vessels are adapted to the structures of the respective organs, and they behave according to the demands of the organ with different features for each organ. And I'll be getting into that a little bit when I talk about the liver and the heart, small intestine later on. I already mentioned the diaphragm is a big part of lymphokinesis. So if we just add it in here on this example of the lymphatic system, as I mentioned, the difference in the pressure gradients. If we move on to the vascular tree and I insert the diaphragm, same thing, here we are. It's commonly known as a pump for the lymphatics and also allows for the negative pressure dynamics above it and the positive pressure dynamics below it. Its optimal position will ensure ideal pressure gradient dynamics, mainly blood and lymph flow, whereas a dysfunctional diaphragm can lead to a cascade of health issues. I cover the diaphragm in more detail in the mediastinal presentation, and once again in the liver lymphovascular terrain presentation. Although the diaphragm is described as a pump for the lymphatic system, it's not officially characterized as a primary or secondary lymphatic structure. Obviously, it's a muscle and a tendon, not an organ, but its role is critical in managing lymphokinesis. The position, shape, function, and tone of the diaphragm will reflect pressure gradient imbalances above and below it. Consider the impact of stress breathing or unconscious breathing or trauma on the position of the diaphragm. The tendency is to observe an elevated diaphragm with increased tone and limited range. You also find adhesions to surrounding organs or tissues. Alterations will also include the pericardial ligaments, having an influence on the pericardial ligaments. And the question is the diaphragm available to properly participate as a lymphatic pump? Key consideration is to appreciate the tendinous quality of the central tendon of the diaphragm. In this case, this is the central tendon part of the diaphragm. This is looking at the diaphragm from below. So a big percentage of the diaphragm itself is very, very tendinous. I suspect it's one of the strongest muscles in the body, given it works about 30,000 times a day on average. Going back to distinguishing between deep and superficial lymphatics, we have this example. This image is a good example of the superficial layers of lymphatics in the upper thorax area versus the deep abdominal lymphatic nodes and structures. The thoracic duct is the primary destination of lymph from the lower extremity, and it remains a deep lymphatic structure as it moves through the mediastinum. So here we have the thoracic duct component of the lymphatic system, traveling deep in the mediastinum. Here's another view of the mediastinum, in particular the thoracic duct in situ. Also, we have the cisterna chyli right here. This is the abdominal confluence of the lymphatics to the right of the aorta. If we put the diaphragm in, it's going to be right about there. We want to note that the left lobe of the liver also, if we put the liver in roughly like this, going over the center, the left lobe is approximately here, and the right lobe is here. As we delve deeper into the celiac plexus, we can see the lymphatic vessels and lymph nodes surrounding the aorta and the vena cava. If we add in the diaphragm, in theory it's traveling above these structures. And it's also important to note that here we have the beginning of the thoracic duct, and this thoracic duct will travel up into the mediastinum. So to add to some of the distinguishing factors, as I mentioned, we already have the thoracic duct, which is a deeper structure. The axillary lymph nodes are superficial. But then you have these deeper structures, as I just showed, around the aorta, the celiac plexus. And here we can begin to see the mesenteric lymph nodes, which are obviously also quite deep. And coming back into the iliac arteries, you can see, following alongside, that you have lymph nodes that are deep. Now, on top of these, there are a lot of superficial lymph nodes laid over top, but these are just sort of giving you an indication of some of the deeper lymph nodes that are present that we often don't see in the lymphatic images. This image shows the anterior sacral lymph nodes that are behind the urogenital organs, and also we can see the lumbar lymph nodes, which are posterior to the aorta and the vena cava. So we're talking about this area here, the anterior portion of the sacrum. You can see how the lymph nodes organize around the arteriole. And then you can begin to see the deeper lymph nodes, inferior gluteal nodes. There are many of them here, and they're quite deep. So when we talk about the pelvic bowl, these are behind the organs in the pelvic bowl. If we stick to the area above the pelvis and we're looking at the small intestine and colon, here we can see a collection of lymph nodes that are closely interrelated to the superior and inferior mesenteric arteries, following along the edge blood supply for the colon. So these are quite deep. Anytime you can see the aorta underneath and the lymph nodes, you know that these are deep nodes. Another example of the deep lymphatic system are the various rectal and pudendal arteries that are supported by the chain of nodes. Here we can see the deeper lymphatic structures transitioning from the common iliac artery down into the femoral artery and then all the way down into the leg. Keep in mind that that lymph flow is moving up back against the flow of the artery. So if we have any issues of density, rigidity, tissue pressure, gradient imbalances in this area, it's going to limit the flow of lymph back from the leg into the pelvis, and eventually it makes it more difficult for the lymph to get to the cisterna chyli and then eventually into the thoracic duct. Looking at cranial lymphatics here, this image allows us to see the architecture of the vascular system, the venous system, and some of the arterial system at the base of the cranium. You can also see highlighted in green the presence of the lymphatic systems. In particular, there is the deeper lymphatic aspect that connects with the deep lymph nodes of the cervical spine. And there's the lymphatic element as well, which is represented in the green here, interacting with the venous sinuses, but there's more detail on the lymphatic coming up. Obviously, the implications of cranial base dysfunction or leading to pressure gradient imbalances or blocking of blood flow on either side of the cranial base with the various foramina will increase cranial pressure, and this will have an impact not just on the lymphatic detoxification element, but also how the lymph collects and travels to connect into the deep cervical lymph nodes. This image is giving us an anterior view of the cervical lymph nodes. Also the nodes around the carotid arteries, internal jugular vein. You can also see the vagus nerve traveling down in yellow, obviously. And as well, you have the retropharyngeal lymph nodes, which can be considered deep cervical lymph nodes. This image allows us to see the aspects of the thoracic duct. We have this subclavian portion of the thoracic duct, which will be in this area on both sides. And then we have the cisterna chyli and the entrance to the thoracic duct right of the abdominal aorta. And so we have the transportation of lymph coming up the thoracic duct and also lymph coming down from the cervical and cranial lymphatics towards the subclavian aspect of the thoracic duct. As I mentioned before, this general image of the lymphatic system doesn't do a very good job of showing us how to discern between the deep and superficial lymphatics, and also that the lymphatics go to almost every layer of the body, including the organs and bone. But let's talk a little bit more about the deep and superficial lymphatics. Deep versus superficial lymphatics. The superficial collectors follow along with the veins, but do not wrap around them like the deeper lymphatic chains. Typically, they run in a straight line. The deep vessels act as a subfascial collector for the extremities, including the truncal wall, which drains the joints, muscles, and bones. They also continue along the vascular bundles consisting of an artery and a vein. The deep lymph collectors are connected to each other in a rope ladder fashion and have a larger diameter than the superficial collectors. This also includes the deep visceral collectors, which proceed along the organ blood vessel, as well as leading to the occasional intercalated lymph node. The lymphatic system follows along the spinal nerve roots as they move away from the spinal cord. And we have intrapulmonary lymph vessels that follow into the lungs all the way to the alveoli, at which point there is no lymphatic support. This image, we can see the intrapulmonary lymph vessels interacting with the subpleural lymph vessels, keeping in mind that these do not include lymph nodes at this level, and only lymphatic vessels. Also note that one of a few places in the body where there are no lymphatics present are at the level of the alveoli. The lymphatics of the lungs are more detailed in the mediastinal lympho-vascular terrain presentation. Continuing the theme of the lymphatic supporting the deepest structures in the body, we have this example involving the spinal nerve roots. So in this case here, we have a lymphatic vessel accompanying spinal nerve root. Here we have lymphatic vessels, a cross-section of the spinal nerve, lymphatic vessels surrounding the nerve. And we have another example here of a lymph vessel that's is continuing to be, this is where you can see the subarachnoid space and the spinal cord nearby and how it's piercing through the dura. And then on the other side of the dura, we have the support of lymphatic vessels. Here we have a typical lymph node. And note that each lymph node has its own venous and arterial support. This means that the lymph moving through the node is entering the venous system at each node. This implies that using the venous angles as a terminus for the lymph flow does not mean that it is the only place in the body where lymph flows back into the venous system, keeping in mind that it's more about the movement of any remaining toxic substances and proteins out of the lymph back into the blood flow for continued detoxification. How healthy is a lymph node if its vascular supply is inhibited or overwhelmed? Rooted in the physiology of the lymphatics is the requirement for optimal blood flow to and from a region or structure. And so we can clearly see that we've got blood flow coming in through the arterial system, blood flow leaving through the venous system, and lymph exiting the node, as well as lymph coming into the node. So there's more than one movement of lymph going on here, in that some of it will come back through the venous system, some of it will continue to be transported to the next node so that it can be supported by another detoxification process. Discussing more the idea of terminal or local drainage back to the venous system of the lymphatic system. As I noted, each lymph node has arterial and venous support going directly in and out. This is an indication that lymph is being processed as it moves around from node to node. This is important because it indicates lymph gets processed back in the venous system through the chain of nodes and not just at the lymphatic terminal points, the venous angles. Stands to reason that lymphokinesis is a localized dynamic and not just a global gradual movement towards the venous angles. We also need to keep in mind that the flow of lymph within the lymphatics is much slower than the rate of relative nearby arterial and venous flow. Fluidic movement with the interstitium is slower even so. So the varying pathways of detoxification express their own rhythms and pace. Additionally, we can conclude that the interstitium is also another detoxification pathway that the body utilizes. Looking at nodes in the context of relative chains, we can appreciate the architecture allows for almost all lymph nodes to connect to at least 2 or 3 other nearby nodes. There's a good example of that in this image. A little bit more on the lymphatic capillaries, which are additional structures involved in lymphokinesis. The lymph capillaries are typically wider and their shape can be more irregular than blood capillaries. The lymph-vascular system is manifest in the finely meshed polygonal interstitial connective tissue as it forms the capillary network. Both blood and lymph vessels are lined with endothelium. There are also precollectors that collect lymph from specific areas of the capillary network consisting of valves that help to drain the lymph into the collectors. The precollectors often connect with other precollectors located around and into organ tissues. The collectors are basically musculoendothelial tubes, which can be further broken down into the tunica intima, tunica media, and tunica externa. The interval of the valves presenting in the deeper lymph vessels is longer than the superficial lymph vessels. So the space between the valves or the flaps is longer in the deeper vessels than the superficial. There are both deep and superficial visceral lymph collectors. The fact that the deeper lymphatics have valves that are at a longer interval indicate that the mechanism of limiting backflow in the lymph channels is challenged at times. It's more reliant on optimal tissue pressure dynamics within the area, in particular local and regional dynamics. Lymphostasis occurring in the deeper lymphatics is akin to inflammation along with the prospect of infection. Putting the capillaries in context, here we can see the interacting lymphovascular terrain acting as a connecting matrix, in particular the lymphatic capillaries. Before moving on to other lymphatic structures, why don't we talk a little bit of what lymph is itself, to give you an idea. But anyway, this image here, you can clearly see the interaction between the veins, the arteries, and all of the lymphatic capillaries in green. And note the diameter changes for each as they become more superficial and as they get deeper. Defining lymph. Lymph is a liquid that flows through your lymphatic system. It is formed from the fluid that surrounds all the cells in your body. This fluid drains from your tissues into tiny lymphatic vessels through flaps or valves in the vessel walls. It's also important to note that the liver produces half of your day's lymph. Lymph can contain water, sugar, proteins, fats, vitamins, minerals, and salts, waste product from cells, germs, bacteria, or toxins. Damaged or abnormal cells as well, including cancer cells. General lymphokinesis or lymphatic flow, unidirectional towards the heart, multidirectional toward neighboring lymph nodes, travels from deep to superficial lymph nodes, as well as superficial to deep if it needs to. Portions of the drainage, such as around the liver, also drain away from the venous angles towards the cisterna chyli underneath. Drainage around the mediastinal portion of the diaphragm also drains down towards the epigastric lymphatics. Virtually every ligament contains a lymph vessel inside it. So just to touch upon, again, the flow of lymphokinesis, we know that it's going from the periphery to the center, from the extremities. Lower extremities will collect all the lymph in the pelvic area and then direct it towards the cisterna chyli and then into the thoracic duct, which passes up, dividing into left and right, connecting into the venous angles. There's also lymph that's coming from the cranium and cervical spine, coming down to connect with the lymph nodes and the collectors towards the venous angle and the thoracic duct. As I mentioned, around the liver itself, there is lymph that will travel down towards the cisterna chyli, over towards the diaphragm, deeper towards the mediastinum, as well as superficially in the territorial lymph drainage towards the right venous angle. There's a lot more information on the liver in the liver presentation. For optimal lymphokinesis, it requires ideal pressure gradients around the arteries. Excessive pressure around the venous angles will limit lymph flow into the angles. Excessive pressure in the mediastinum will limit lymph flow to the thoracic duct. Excessive upper cervical or pleural dome tension will limit lymph to the venous angles. Excessive tone in the diaphragm will limit lymph flow at the thoracic duct. Suboptimal liver function will limit lymph flow. Suboptimal intestinal function will also limit lymph flow. So what is it exactly that creates resistance to lymphokinesis, resulting in edema and inflammation anywhere in the body? For that, we need to investigate the pressure gradient environment of the human body, also known as the living bioplasm of connective tissue and fluids. The presence of fluid and tissue tensegrity and pressure helps compartmentalize or distinguish various structures and fluids from each other. In the foot of a standing person, the arterial blood pressure is about 200 millimeters of mercury, but the venous return flow is only 100 millimeters of mercury. The pressure in the venous system steadily falls the closer it gets to the heart. Lymph pressure is lower in the initial lymph vessels, and it elevates as it coalesces centrally until it reaches its maximum at the thoracic duct. Lymph flow traveling back to the thoracic duct and venous angles must pass through various tissue pressures. The more tissue pressure, the more resistance to lymph flow or lymphokinesis. Arterial pressure will cause surrounding tissues to reflect the pressure imbalances, meaning that the connective tissue will respond accordingly to any imbalances within the arteries. This involves the interstitium as well as various fascial layers and connective tissues. And this is the most obvious example of this would be guarding of tissues. It's my estimation that the guarding is stemming from the body's need to protect blood flow, prioritizing that over the protection of any parts of the nervous system. The pressure gradient environment. The human organism relies on optimal pressure gradients between tissues and organs in order to sustain homeostasis. This is an example of structure governing function, one of the keys in osteopathy. The simplest example of this is blood pressure. The pressure inside the lymph capillary is about 1 millimeter mercury at rest, and the flap valves are closed. Lymphokinesis is reliant on optimal tissue pressure. Tissue resistance and compression results in accumulation of pressure, lymph, and toxicity. In regards to talking a little bit about blood pressure, I think what's important to remember in this context is when we are measuring, or someone's having their blood pressure measured with the blood pressure cuff, this is not designed to assess the heart per se. This is designed to assess the workload of the entire body working together in order to maintain an ideal sense of blood pressure. So when blood pressure is high, it's an indication that there are aspects of the physiology that are having to work harder in order to move the same amount of blood to all areas of the body. The reverse is true if it's low blood pressure. Role of pressure. The human body is essentially a metabolic sponge of varying densities with fluid concentration gradients, tissue pressure gradients, connective tissue tensegrity, and ideally optimal microbiome diversity. The fluidic concentration gradients will includes chemical concentration gradients. Optimal lymphatic flow requires that tissues reflect ideal pressure gradients. This is local and regional and global. And chemical gradients, since they surround the vascular structures and act like a three-dimensional sponge. The functioning of the heart and arteries requires optimal pressure characteristics to sustain blood flow demand and requirements. Continuing with interstitial pressure gradients, when mechanisms that are required to protect against edema fail, the result is an increase of interstitial pressure and a reduction in the effective lymphatic ultrafiltration rate. The effective ultrafiltration rate will remain unchanged if the interstitial pressure does not change. This creates stasis, the lymphostasis. Lymph formation, however, will increase if there's an increase in interstitial pressure, leading to further lymphostasis. This explains why all cases of generalized edema primarily appear where the fluids can easily accumulate in the interstitium that is most compliant. An example would be the eyelids or the scrotum upon waking, as a general lymph flow is sluggish at night due to immobilization. Looking again at an image of the interstitium, we can see that the entire structure is reliant on these compressive forces. And then we also have the interactions, the tensegrity and the chemical gradients in the interactions, whereby the various toxins are leaving the bloodstream, entering into the interstitial area, and then being brought into the lymph collectors and then deposited to or transitioning to nearby nodes. Going back to the image of the lymphovascular terrain, we want to add the hidden feature of pressure gradient dynamics implicating tissues and fluids, and the transportation of toxins through osmosis or diffusion. When this mechanism breaks down, that's when we start to get the lymphostasis. An example would be if we have the arteriole here on this side. If we just talk about that for a moment, and we implicate it in contracting, so the size of the artery would somehow contracted be under tension. So the natural mechanism is for the body to contract when it's actually requiring more blood as a way to entice the blood to come towards it. Once you get an artery's dimension or tone changing into a contraction, what happens is around the artery, now you start to get a response from the system. So these tissue cells, which is part of the connective tissue system, they also will contract and organize around the artery. In fact, the entire mechanism will start to contract because the system is organized around the artery, as I explained from an embryological perspective. So then you get a massive lymphostasis consequence. That will lead to degenerative tissue disorders. And an example of that is you wake up with stiffness, joint aches, fatigue. And of course, these seem to improve once you get moving. You'll also get puffy eyes, face or fluid around the breasts or axilla. You can also get abdominal bloating, pelvic bloating, puffy arms, legs, ankles, or feet, especially post-sitting. And then it ends with recurrent infections, sinus or respiratory, or even bladder, the chronic issues that usually lead you towards having to use some type of antibiotic intervention. Accompanying lymphostasis will be inflammation. There's evidence that controlling the inflammatory process depends on the ability of the lymphatic system to remove and deactivate chemical and immune mediators. These mediators control the process of inflammation. Disease that depends on lymphatic drainage for resolution include asthma, pancreatitis, rheumatoid arthritis, and myocardial infarction. That's coming from Sephinger. Continuing with lymphostasis and inflammation, tissue degeneration will be the result of prolonged inflammation as well as smoldering infections and tissue destruction brought on by chronic inflammatory processes. There is also evidence that the removal of cytokines, leukotrienes, prostaglandins, bradykinin, and histamine is dependent on the proper function of the lymphatic system. Of course, recent perspectives on inflammation include a new concept called hidden inflammation. Talking about hidden inflammation, according to gastroenterologist Shilpa Revela, there appears to be a cost for our modern environment and its various elements of toxic overload in the form of what she calls hidden inflammation. According to Revela, the biomedical framework of the 19th century divided organ systems and an understanding that a specific cause results in a specific disease. This is no longer effective for most health conditions that plague us today. Effectively, combating hidden inflammation begins in delving deep into its root causes. Human genetics, which have remained relatively constant or longer lifespans, cannot alone explain the steep rise in chronic inflammatory diseases over the last decade. Our destinies are largely shaped by lifestyle. Some examples of hidden inflammation. Typically, hidden inflammation can be located alongside organs and in specific spots throughout the body, including inside various vascular and lymphatic vessels. Lifestyle diseases have a cynical nature as the metabolic implications play themselves out within the ecosystem of the human body, lurking beneath complex physiological degeneration. This may present as developing tumors or heart disease or diabetes, obesity, even psychiatric and especially neurodegenerative disorders. There may also be a few signs or symptoms of hidden inflammation that are expressing themselves as arthritis, eczema, psoriasis, chronic pain or swelling with redness. That's all coming from Revela. Bruno Schickli describes edema in the following ways, which is another way of looking at hidden inflammation. It is defined as an accumulation of excessive fluid in the tissues and as a hydrocolloid in the body. In particular, it is a swelling. In the case of local edema, we can include those that involve excessive buildup of fluids that occur in body cavities. When there's an accumulation of fluid in the peritoneal cavity, it is referred to as ascites. When it occurs in the pleural cavity, it is defined as hydrothorax. When it occurs in the pericardial cavity, it is known as hydropericardium. When it occurs around the testes, it is called hydrocele. And when it occurs in the oviduct, it is referred to as hydrosalpinx. Circumscribed edema refers to edema being restricted in its movement. Circumscribed edema, or lymphostasis, and relative acidosis are often found in the layers of superficial fascia where there is participation of the subdermal lymphatics. This distinctly doughy feeling, found upon palpation, is implicated in the existing factors of uncovering an osteopathic lesion. Typically, the area of enlargement or edema includes toxins or infection and is often accompanied by dysfunction in the nearby lymphatics. That's coming from osteopath Tom Dummer. And he speaks to the importance of looking at edema as an actual osteopathic lesion in terms of the lesion classification that is used in osteopathic manual therapy. The challenge is that unless it's an acute injury that's producing the edema, the observation of edema as a as a indicator of health is not emphasized enough in the initial clinical examination. Osteopathic physician Frank Millard has this to say about edema. No organ or ductless gland can be involved to any great extent without reflecting its disturbance and blockage in some palpable area. We must look for edematous areas. They are certain areas that denote specific organ lymph blockage. The watching of these regions that are prone to puff is very essential. Learn to detect puffy areas. Edema from the point of view of Foldy. Foldy defines the clinical definition of edema as a swelling that is the result of an increase in the amount of fluid situated in the interstitium that is visible or palpable to our senses. Extracellular edema can be accompanied by intracellular edema in cases of mechanical and combined lymphatic vascular insufficiencies. Edema must be categorized only as a symptom and not a diagnosis, except for mechanical insufficiency contributing to diagnosed lymphedema. The clinical significance for practitioners. Osteopathic practitioners and other manual therapists are poised to directly influence lymphokinesis. This happens with an understanding of lympho-vascular terrain so that we can better influence the outcomes of edema, hidden inflammation, chronic pain, autoimmune disorders, and many recurrent lifestyle-related degenerative processes that are connected to inflammation. It's important to understand that the body is an ecosystem that has the qualities of living terrain that is self-organizing until it is met with resistance in the form of tissue densities, or tensegrity imbalances, or pressure gradient imbalances. So talking about some of the components of lymphatic terrain, we have lymphatic capillaries, vessels, and some of the primary and secondary lymphatic organs. The lymphatic capillaries participate in the formation of lymph from the interstitial fluid within the interstitium. So they are small structures that are connected to lymphatic vessels. In turn, these vessels draw the lymph from the lymphatic capillaries and move it towards the nodes. There's a difference between primary and secondary lymphatic organs, as the red hematopoietic bone marrow and the thymus are classified as primary lymphatic organs, and the secondary lymphatic organs include the lymph nodes, the mucus itself, which is part of the MALT, mucosal associated lymphoid tissue, the spleen, and the interstitium is now classified as an organ. And according to the Cleveland Clinic, tonsils and adenoids are classified as part of the lymphatic system. I would add the appendix as well, as it has been shown to contain a super probiotic bacteria that can't be found anywhere else in the body. So looking at other lymphatic structures, I'm going to begin to introduce some of the aspects and organs that are not listed as primary or secondary in the traditional sense. These are structures, organs that participate in lymphokinesis. They contribute to the immune response, and they're certainly part of the detoxification pathways. And as I mentioned, they're not classified as lymphatic organs, but I'll make the case that they're participating either in the formation of lymph or in the transport of lymph. Moving on to what osteopath Frank Millard had to say in his initial observations. Talking about lymphokinesis in organs, in general, all organs in the body have lymphatic collecting vessels that are responsible for draining the portion of the tissue or organ that is nearby the vessels. It's important to consider that this is coming from 100 years ago, and the use of the term vessels you could easily interchange with capillaries, since capillaries would be the smallest collecting vessels, and then the next size up would just be lymphatic vessels, and then moving from then towards the lymph nodes. Lymph lines typically follow the path of least resistance as they accompany tubes and vessels on their way back to the terminal points. So they're accompanying the arterial system and the venous system, all the while going against the arterial flow and often succeeding where the resistance to lymph flow is limited. So again, this is coming from Millard, 1922. If we consider the effects of tissue resistance, that's usually accompanied by vascular constriction, as being a limiting factor towards global lymphokinesis or local or regional lymphokinesis. We might want to put an emphasis on the liver, which is not listed as a primary or secondary participant of the lymphatic system, but I'll make the case that it is a key participant in lymphokinesis. Just a few examples of the many attributes and connections of the liver to the lymphatic process. Most organs in the body have lymphatic aspects that both support the organ itself and its internal lymphokinesis, and also the organs are connected to surrounding lymph nodes through the vessels, which ultimately connects to the entire body. So in the case of the liver, it's just like any other organ in the body, except it has a large surface space. But there are critical functions that the liver completes, which are notable. Going back to Millard, what he had to say, the liver is the chief organ in systemic pollution. That is, in the majority of cases, the liver is involved primarily and the other organs are affected secondarily. If the lymph drainage of the liver is blocked, it is only a short time before some other organ will take on a diseased condition. The liver has intrahepatic lymph capillaries that are in the interlobular connective tissues inside the periportal space. There are lymphatic structures inside the periportal space. They receive lymph from a lobule of the portal vein. Continuing with the liver and lymphokinesis, this is a brief description. More detailed description you'll find in the presentation on liver lymphovascular terrain. The liver produces about 1 liter of lymphatic fluid each day from the protein-rich fluid of the perisinusoidal space, otherwise known as Dissay space. So if we ponder that for a moment and just think, almost half of the lymph that's produced every day is coming and being manufactured inside the liver. So it's not just the lymph that's being produced in the interstitial tissue. We rely on the liver to be a big player in the production of lymph. And that's, I think, understated in many respects when it comes to the liver. From the Dissay spaces, the lymph then flows along the sinusoids and the efferent inlet venules towards the surface of the lobuli. So it goes from the center of the liver to the surface of the liver, which then it will connect with other lymphatic structures and vessels. The Dissay spaces are bordered on one side by the intrahepatic blood capillary sinusoids of the portal vein, and on the other side by the hepatic cellular plates. So again, the Dissay spaces are vulnerable to pressure dynamics since they are not far from the aspects of the portal vein and the hepatic cellular plates. When that architecture starts to lose its identity, then that will affect the movement of lymph and the production of lymph in the liver itself. The Disse spaces act as pre-lymphatic channels inside the liver. These channels travel to the initial lymphatic vessels situated in Moll's periportal spaces. Pre-lymphatic channels also occur in the spinal cord and the brain. That's coming from Foldy. This is just a rendition of the liver and the interplay of the lymphatic components that are helping produce 50% of the lymph on a daily basis. Fortunately, this diagram, the hepatic vein is listed here, and it's actually, lymphatic vein is here, obviously in the blue, and this is the hepatic artery, so that's a correction. But you can see the spaces of Disse here, hepatocytes, and all of this is under the influence of the pressure within the liver itself. Again, looking at an image, a histological image of the architecture of the liver, you can see it looks very similar to a sponge. So it has this ability to contract and expand. Within the architecture of the liver tissues, we have the plumbing of the venous, arterial, and biliary systems. Also next to the hepatic artery entering the liver is the portal venous system. And then in the opposite direction, you have the bile leaving the liver via the bile duct. Because the liver acts like a metabolic sponge, we can assume that this role as a blood pressure mediator is also important. Under basal conditions, the liver requires 22% of total blood flow to optimally participate in homeostasis. That means basically when you're at sleep at night. But in addition to that, the small intestine, which also receives around 21% of the blood under basal conditions, that will also end up in the liver. So you get about 40 to 45% anywhere of total blood is making its way through the liver at some point, trying to when we're at rest. A little more specifically around the blood flow to organs and tissues under basal conditions. The brain gets about 14%, the heart 4%, the bronchi 2%, the kidneys 22%, the liver 22%, from the portal vein, small intestine 21%. I guess the portal will also include the aspects of the colon as well. And arterial is 6%, and muscle in its inactive state, obviously basal conditions, 15%. And then finally you have 5% going to the bone, 6% to the skin, 1% to the thyroid gland, 0.5% to the adrenal gland, and various tissues at 3.5%. And that's coming from Guiton and Hall. So in terms of the circulation to the liver, or hepatocentric circulation, the blood flow coming to the liver, by controlling local blood flow in such an exact way, the tissues almost never suffer from oxygen and nutritional deficiency, and yet the workload on the heart is kept at a minimum. That's in reference to the division of blood to all the different organs in the body. Reminding you that only 6% of the blood is traveling through the heart when we're at rest. In general, the basal blood flow to a tissue is maintained at or slightly than a tissue's metabolic requirement. It's important to note, again, that between the liver and the portal system, we have approximately 44% of total blood supply dedicated to homeostasis. Historical precedents had a grasp on the importance of the liver, as Sergiano Giovanni Riva, back in the 1600s, concluded that the circulatory system was based on the hepatocentric model provided by Galenic physiology, which suggested the blood was created in the liver. So this is before they really knew what was going on with the circulatory system. Now, obviously, the theory was incorrect, since the blood's not created in the liver, but lymph is, and that does require blood. In addition, I guess I can only rationalize that this theory developed from observations that the liver contained a great deal of blood at any one time, which was likely discovered with the exploration of live cadavers. So here's the drawing from earlier anatomists of hepatocentric circulation. Although we consider the heart to be the master of fluids and circulation, it does not contain or hold as much blood as the liver or the portal system. Unless you're actively up and moving around, it's basically two muscles where one works as a suction and the other as a pump. But the blood doesn't really stay in the heart, it just travels through it. So this diagram, I really like this diagram because it does give you an indication. We're dealing with the liver in this area, and they're giving you the vascular aspect of it. So it's easy to see why they would have thought that the liver was the center of the circulatory system, given the way that if we go to the venous system, the portal system is coming back, bringing blood from the abdomen and pelvis, and in general it's receiving blood off of the hepatic artery. An embryological distinction with the liver. In the fetus, the liver is the main center of hemopoiesis, and it evolves from an endodermal invagination of the foregut and from the septum transversum mesenchyme. Liver is one of the most precocious embryonic organs. It's coming from standing. So I suppose Galen's theory of hepatocentric circulation wasn't entirely wrong. We can appreciate the significance of the morphogenic imprint embodied by the liver, since at one point it is producing blood in the fetus. I get a little more specific again on the liver in the liver lymphovascular terrain presentation. Again, going back to liver and lymphokinesis, or the movement of lymph. So we'll know the alterations in the shape, the size, the weight, and position of the liver will have an effect on blood pressure dynamics and fluidic retention. Blood pressure or pressure gradient imbalances represented in tissues as resistance will have an effect on lymphokinesis. The normal tone of the hepatic artery and its branches are responsible for augmenting the lymphatic drainage of the liver. And that again is coming from Millard. Can the liver be considered a hub for lymphovascular terrain? Well, in addition to producing lymph and participating in the detoxification pathways, the movement of lymph is unique around the liver. Lymph will travel from the liver via lymphatic vessels to nearby nodes in multiple directions. It's as if the system is designed to ensure more than one direction of lymph transportation is always possible to prevent lymphostasis and tissue degeneration in and around the liver. So an example would be if we are to place the liver roughly in its position, which would be somewhere there, crossing the midline. There. Yeah. And of course, above it, we would have the diaphragm. So what we get, in fact, is there are vessels coming in towards the liver that are blending in from the mediastinal lymph nodes, and also from the gastric lymph nodes. So there's a direction of lymphatic flow through the nodes and vessels that goes towards the connectors to the liver. And primarily, as I've said, the direction of lymph is up the thoracic duct to end here at the venous angles, obviously. Now, this doesn't give us a three-dimensional view, but there are also lymphatics around the diaphragm that are connecting with the lymph of the surface of the liver. And there are the lymph collected from the liver also moves down towards the cisterna chyli. Now, this is one of the few places where the lymph is moving against the flow. So everything else is moving towards the thoracic duct, but this lymph in the liver comes down and connects. It also has lymph nodes that are along the hepatic artery, which I'll be showing in a little more detail. Hepatic artery coming off the aorta. So there are countless lymph nodes in that area that are interacting with the epigastric lymph nodes. This image gives an indication of the connections with some of the lymphatic structures surrounding the liver as it's moving in multiple directions. Now, the liver's not in this image, but we would be looking at putting the liver in here underneath the diaphragm. And you can already see here that they're giving an example of the lymph nodes that are interconnecting with the diaphragmatic lymph nodes and connecting with some of the mediastinal lymph nodes. And so these are not superficial, these are deeper connections. And then again below here they're connecting with the epigastric lymph nodes and the hepatic artery lymph nodes. Placing the liver back in situ, we can appreciate here the organization of the lymph nodes supporting the liver, connecting to the epigastric lymphatic complex. So here we have the stomach and its associated lymph nodes, and you can see anywhere there's arterial supply, there are associated lymph nodes that are sort of wrapping around and next to the arterial supply. So there's a great deal of lymph nodes in the epigastric area. But in particular, there is an interaction here where this lymph is moving downwards towards the epigastric. So instead of moving up towards the thoracic duct, it's coming down to enter the thoracic duct below the diaphragm. Quick summary of the liver. The liver is a type of metabolic sponge with the capacity to produce 50% of the lymph for the entire body. It contains pre-lymphatic collectors that move lymph to surrounding lymph nodes, and this assists in detoxification of the liver tissues themselves. The liver is a lymphatic hub that is surrounded by lymph nodes, which send and receive lymph above and below the diaphragm. Even the suspensory ligaments of the liver contain lymphatic capillaries, and those are the triangular and coronary ligaments. Important to remind the viewer that a much more comprehensive description of the liver and its relation to homeostasis and the lymphovascular terrain can be found in its liver lymphovascular terrain presentation. Let's move on to some other organs that we could characterize as being part of the lymphatic system that are not classified as such. Before I do that, let's just talk a little bit about how we can improve lymphokinesis in regards to the liver. Treatment intervention goals include restoring the independence of liver function in relation to its neighboring structures, liberate the liver from the diaphragm, stomach, ribcage, and surrounding connective tissues, restore the ideal shape, tone, and blood flow to both the left and right lobes of the liver. We want to distinguish the gallbladder complex from the surrounding liver. And we want to restore liver pliability and PRM so that it functions independently of the respiratory mechanics of breathing. In short, by liberating the various aspects of the liver function, we are restoring optimal blood flow. Optimal blood flow allows for optimal lymphokinesis, as well as the potential for all metabolic activities of the liver to succeed. It's a good example of structure governing function. So moving on from the liver, we'll look at another organ that's not listed as a primary or secondary lymphatic organ, but it supports lymphokinesis when it's functioning optimally, and that organ is the heart. I think it's also worth including the heart as a lymphatic organ in terms of its function and its influence on lymphokinesis. The heart can be described as having two muscular pumps within one structure. One pump will serve the lungs and the oxygenation of blood, and the other serves the rest of the body with systemic circulation, otherwise known as vascular tree. That's coming from Gray's Anatomy. Cardiac hemodynamic insufficiency can affect the entire venous system of the body, including at the venous angles. So we can have systemic issues if we have hemodynamic insufficiencies or pressure gradient imbalances occurring in the mediastinum around the heart. A disturbance in the Starling equilibrium causes the compensation of an increase of lymph flow per unit of time. When the lymphatic vessels cannot adapt to the situation, it can lead to cardiac edema. Furthermore, during right ventricular failure, the lymph vessel workload doubles. Lymphostasis will occur with a disruption within the mediastinal pressure gradients. The Starling principle states that fluid movements between blood and tissues are determined by differences in hydrostatic and colloid osmotic and oncotic pressures. This is between the plasma inside microvessels and the fluid that's outside of them. In most tissues, steady oncotic pressure differences between plasma and interstitial fluid depend on low levels of steady filtration from plasma to tissues. Plasma volume is normally maintained by fluid losses from filtration being matched by fluid gains from lymph. Steady state fluid uptake into plasma only occurs in tissues such as intestinal mucosa and renal peritubular capillaries, where a protein-free secretion of adjacent epithelial cells contributes significantly to interstitial fluid. Steady filtration rates in different tissues are disturbed locally by reflex changes in capillary pressure and perfusion. So this is the pressure dynamic that exists around arteries and the ability of the detoxification process of various substances and proteins to move into the interstitial space, to be picked up by lymphatic structures. And this is how we this is one of the areas where we get edema, and lymphostasis is in the interstitial spaces. This can occur around organs as well, which is why I'm discussing the heart in this context. From a practitioner's point of view of treating the heart, we want to restore the ideal shape, the position, the function, the resonance, and balance the inherent nervous system tone. We can support that endeavor by treating the cranial base, freeing up vagal participation. The mediastinum has negative pressure gradient properties compared to below the diaphragm. This assists in the suction component of cardiac physiology, ideally assisting the return in venous flow. Increased tissue or arterial pressure will limit the ability of lymphokinesis or lymph to return back to the mediastinum via the structures such as the thoracic duct and the venous angles. Any alteration in the pressure gradients of the mediastinum due to increased tone of the muscular aspects of the heart or in the pericardium, keeping in mind that the mediastinum located above the diaphragm provides a negative pressure that acts like a suction for blood and lymph coming back. Below the diaphragm, we have a positive pressure gradient, which supports blood flow from the center to the periphery. Here we can appreciate that the pericardium is surrounded by deeper lymph nodes of the mediastinum, including a portion of the thoracic duct. These are not superficial lymphatics, and local lymphokinesis will be limited if the position of the pericardium or its tone is compromised, or if the heart muscles themselves are under increased tone. A much more comprehensive view on the mediastinum lymphovascular terrain will be available in my Part 4 presentation. Here in this image here we've got the pericardial bag, and the heart within it. So we can also see the collection of lymph vessels, the chain of lymph vessels that are organizing down through the center of the body. And they connect with superficial lymphatics. And they also connect down through the diaphragm to connect with the lymphatics supporting the aorta and the celiac plexus. This image allows us to see that the heart itself also has a requirement for lymphatic drainage. You can see lymph from the heart and surrounding tissues will make itself or make its way to the bifurcation lymph node, which is located right here. And then you've got cardiac lymph node up here, and this is your venous angle in this area. When we remove the heart and pericardium, we can view the deeper lymphatic structures and lymph nodes which support the lungs, the diaphragm, the trachea, and the esophagus. Also note again the thoracic duct at the center of them all. Just imagine what would happen if the dysfunctional heart increases mediastinal pressure gradients and leads to lymphostasis deep in the chest cavity. This would be an extreme example of hidden inflammation that lingers and potentially ends with a degenerative tissue spiral and eventual infection. We can also consider that chronic infections are also linked with lymphostasis anywhere in the body. So again, here in this particular image, we've removed the heart, and we can see the accompanying lymph nodes for the coming off the trachea, and these are all deep lymph nodes. And then note that you have the chain of lymph nodes still connecting down through from the lumbar lymph nodes and connecting with other lymph nodes on top of the diaphragm. Then we also have lymph nodes that are supporting the lungs with interlobular lymph nodes. And here at the center, we have that little view of the thoracic duct itself. So this entire mechanism requires ideal pressure gradients so that not only can the lymph move properly upward towards the venous angles and through the thoracic duct, but you also have the movement of lymph that is going from superficial to deep and deep to superficial nodes as well. Just a quick summary of the heart. It's the master of fluids. It's surrounded and inundated with lymphatic structures inside and outside of the pericardium. Lymphokinesis to the mediastinum is reliant on ideal pressure gradients within and surrounding the heart. Alterations in the overall shape or tone of the heart muscle or muscles or the position of the pericardium can affect local and global lymphostasis due to pressure gradient imbalances. The heart participates in the deeper lymphatics as it will influence lymphokinesis towards the thoracic duct and venous angles due to its effect on mediastinal pressure gradients. Looking at the role of the diaphragm as a lymphatic pump, quite possibly one of the strongest muscles in the body. The diaphragm powers the thoracic pump as it sits beneath the lungs in the shape of an umbrella. During exhalation, the diaphragm ascends and tightens as it shrinks towards the lungs. During inhalation, it will descend and expand. This continuous movement occurs roughly 30,000 times a day. Adults typically only utilize 10% of the available range of the diaphragm when breathing, and this leads to overburdening of the heart. The result can be elevated blood pressure and many circulatory related problems. The diaphragm can be considered a second heart as it moves to its own rhythm, as well as influencing the function of the heart. Studies regarding the function of the diaphragm in emphysema patients confirmed by X-rays has shown that excursion of the diaphragm was severely limited in range of motion. The cause appeared to be a gradual atrophy due to lack of use. Looking at the diaphragm from an osteopathic point of view, the diaphragm is a dome-shaped muscle with two lateral hemidiaphragms whose shape is influenced by the viscera. In addition to inspiration and expiration, the diaphragm is important in micturition, defecation, parturition, circulation of blood, lymphatic pumping, and speech. The respiratory diaphragm may also reflect the torsion pattern by tensing, leading to a host of secondary symptoms, including shallow breath, tight chest, general inflexibility, and nerve sensitization. I've seen this as a common finding when working with infants and adults alike. That's coming from Franklin Sills. Although the loss of ideal function of the respiratory diaphragm is an example of loss of adaptability and viability at any age, there are specific characteristics that are present in an aging population. The elderly experience a decrease of 10 to 41% transdiaphragmatic pressure, otherwise known as PDI, and a decline of 30% in overall expiratory strength. This ultimately influences the speed of contraction and the decline in muscle coordination, leading to an increase in falls. In addition, other symptoms include urinary incontinence, dizziness, depression, anxiety, and obstructive sleep apnea syndrome. From a postural perspective, we see the advent of dorsal kyphosis, decreased elasticity of pulmonary parenchyma, stiffness of the joints in the chest, and hyperinflation. The hyperinflation is a result of an increase in residual volume and functional residual capacity. The thickening of the diaphragm can also lead to vagal nerve degeneration as the vagal nerve innervates the portions of the diaphragm. That's coming from Bordoni in 2020. That's in my references. The diaphragm is also part of osteopaths Philip Druelle's central chain, his description of anatomical connections that are traveling relatively central in the body, starting at the vertex to the third ventricle, the sphenobasilar symphysis, the esophagus and trachea, the pericardium, central tendon of the thoracic diaphragm, the head of the pancreas, the root of the mesentery, the uterus isthmus, and the central tendon of the perineum. And these structures are have a connection, a consistent connection through connective tissues. So there are tensegrity implications traveling through the body. They also help the body organize around the aorta and aspects of the central nervous system. More specifically, the central chain descending right of midline goes to the coronary and triangular ligaments of the liver, passes through the liver falx to the head of the pancreas. When it descends through the midline, we have the lesser omentum, hepatogastric ligament, and the head of the pancreas. This image, we can appreciate the size of the central tendon and its potential influence on the overall muscular tone of the diaphragm. And so here is the central tendon portion of the diaphragm. And then on the outside, we have the muscular aspect of the diaphragm attaching to various ribs. Some more information on the lymphatics with the diaphragm. The lymphatic drainage of the deeper tissues of the thoracic diaphragm wall occurs via the diaphragmatic nodes closely following along all of the arterial branches. There are a small group of lymphatic nodes underneath the xiphoid process, and those are relatively superficial. There are intercostal nodes. They eventually drain into the abdominal confluence of lymphatic trunks. There are also lymph nodes at the point near where the phrenic nerve enters the diaphragm. So the phrenic nerve is getting support from lymphatics as well. Afferent lymphatic vessels on the right side of the diaphragm also drain the convex surface of the liver. There are also nodes at the posterior aspect of the crura. There are also lymphatics that primarily drain the muscles that attach to the ribs. And there are lymphatic vessels of the deep diaphragm forming a lymphatic plexus anastomosis with the nodes of the abdominal plexus. Just looking back at this image again and wanting to appreciate the top of the diaphragm here and the collection and chains of nodes. Some are passing through the opening, some are on the top of the diaphragm, and they're connecting with the other chains of nodes that are working and supporting also the thoracic duct, supporting the lungs, surrounding the trachea, and this is again with the heart removed. This image again, we have an example of the diaphragm here, and we also have, we can see the various nodes supporting the diaphragm here, and you even have the pericardium here, so you can see these lymphatic vessels connecting to nodes, moving around, supporting organs in the area. There's another critical component of the lymphatic system which contributes to lymphokinesis and that's the small intestine. I'm just going to go over the vascular supply before I go into the lymphatic aspect and how it contributes to immune system, absorption, etc. The small intestine's arterial supply arises from the celiac trunk and the superior mesenteric artery. The superior pancreaticoduodenal artery, SPA, originates from the gastroduodenal artery, which branches from the proper hepatic artery and is traceable to the celiac trunk. So it all sort of branches that come off of the celiac trunk as it comes down below the xiphoid process off of the aorta. The SPA anastomoses with the inferior pancreaticoduodenal artery, the IPA, which comes from the superior mesenteric artery to supply blood to the duodenum and other aspects of the intestine. As the name suggests, the SPA supplies the superior duodenum while the IPA supplies the inferior duodenal segment. The gastroduodenal artery runs on the superior part of the duodenum's posterior medial wall. The lymphatics of the small intestine. Small bowel lymphatic vessels follow along the arteries, much like a vine trailing on a branch. Lymphatic drainage starts at the small intestinal mucosa and goes into the nodes near the mesentery, arterial arcades, and the superior mesenteric artery. Keep in mind, I've already discussed the mucosa as being a component of the lymphatic system as it interfaces with the epithelial cells. Efferent lymphatic vessels from the superior mesenteric lymph nodes flow into the celiac lymph nodes. So they're making their way from the aspects of the small intestine, superior mesenteric artery, back towards the center. Lymph then drains into the cisterna chyli and up the thoracic duct into the venous system at the left venous angle, where the left internal jugular and left subclavian veins meet. Now that's just a reference to the fact that the lymph from the lower extremity culminates at the thoracic duct, moves up and drains onto the left side. As I discussed before, there's a difference between the left subclavian vein and the right subclavian vein and its sorted lymphatics. The small intestine's lymphatic drainage is a major transport system for absorbed lipids and immune defense system, and as well small intestinal cancer cells. Here we have an image of the superior mesenteric artery as it branches off the aorta, places the viewer at the head of the patient looking towards the feet. Obviously there'll be variations of this theme, but you can see clearly the image represented, which is a tree. If we add in other aspects, the aorta itself would be something of this nature, and the superior mesenteric artery branches off anteriorly. Up here, further up the aorta, we would have the greater hepatic artery, and here we would have the splenic artery, gastrosplenic artery heading towards the spleen and the stomach. A little bit lower, we have the right renal artery and then the left renal artery. And obviously down below, there's a bifurcation going into the right common iliac and the left common iliac artery. So this image is showing you the complexity of the blood supply to the small intestine. And we need to keep in mind that as we look at in situ, here we have the example of the superior mesenteric artery. Now we can see the addition of the lymph nodes following along, trailing along all of the various branches. Now these are just the lymph nodes that are adjacent to the superior mesenteric artery. In regards to the small intestine, I'm going to present an image of the microvilli. And it's important to keep in mind that approximately 40% of all lymph nodes are located in and around the small and large intestines. Now, although this image is not showing any actual lymph nodes, it is showing you the architecture within the intestinal wall. And there's some important aspects to it here to consider. One of them is, here's your microvilli, and within the microvilli you can see the artery, vein, and lymphatic vessels. So each individual microvilli has that component to be able to absorb nutrients and help detoxify blood. And as well, that blood will be delivered to the venous system, where it will make its way to the portal system as well. You also have here the orifice or crypts of Lybracun, and these are areas of distinction for microbiome. And there's also lymphoid follicles, which we've got here, which are just smaller follicles which also participate in the lymphatic system or detoxification process. And then you do have your mucosal layers and submucosal layers as well. And within those layers, you will have a microbiome component as well. Now, on the outside of the intestine, the microbiome is critical because it's helping with the interface between the food we bring in and the absorption of the microvilli. The small intestine, from an osteopathic perspective, it's important to have adequate blood supply to the mesentery and other organs. It allows for the correct functioning of the lymphatic system. When the vascular tree becomes compromised, the lymphatic system will be sluggish and the nodes will begin to enlarge. And that again comes back down to the pressure gradients within a localized or regional area. It's important that the walls of the blood vessels maintain their required tone so that the lymph can flow without restriction. And again, it's the blood vessels that set the tone in surrounding tissue, which also involves interstitial tissue or connective tissue in general. So when there's improper tone in a blood vessel, then the surrounding mechanism of lymphatics, osmosis, and diffusion, all those aspects will be compromised, leading to lymphostasis, and eventually leading to to overwhelming a nearby lymph node. Normal blood flow in the small intestine equates to normal functioning of the surrounding nodes. Organs that have become diseased are responding to disturbed circulation regardless of any contributing variables. Vascular supply can be restored by removing cause, and disturbed circulation to organs will interfere with the mechanical function of the organ. That's coming from Millard, and he's probably the father of the lymphatics going back over 100 years. A summary of the small intestine. The intestinal lymphatic system is comprised of two non-communicating lymphatic networks, one containing the lacteals draining the villi and the connecting submucosal lymphatic network, and one containing the lymphatics that drain the intestine muscular layer. The intestine contains 3 layers of lymphatics, including progressing from the luminal surface to the serosal surface, the lacteals in the villi, a submucosal lymphatic network, and a lymphatic network in the smooth muscle layer. Small intestine lymph nodes are known as the mesenteric lymph nodes, and they form perhaps the largest collection of lymph nodes in the entire body. There are approximately 150 nodes spread out through the entire mesenterium. They may be divided into the juxta-intestinal, intermediate mesenteric, and central mesenteric lymph nodes. Some other components of lymphovascular terrain: we have the mucosal-associated lymphoid tissue, otherwise known as MALT. Now that changes its name as the mucosal layers travel through the body through pretty much all tubular structures all the way down into the pelvis. This includes entire ear, nose, throat passageways, respiratory tract, digestive tract, and the reproductive tract. All those areas have some aspect of mucosal lymphatic tissue. All endothelial and epithelial line structures have one or more mucosal layers forming an immune barrier. The microbiome and bacterial environment is embedded in various mucosal layers and is proving to be a critical factor in the dynamics of health within the terrain. So that's going to be predominantly involved in the digestive aspect of the epithelial cell mucosal layers. Optimum terrain function also exhibits the aspects of the structured water phenomena within endothelial and epithelial cellular integrity, and you can look more at the structured water phenomena. You can look at a recent book called Osteopathy is in the Blood, where they go a little more detail into structured water, or you can look at Dr. Cowan's work, Cowan, and he talks about structured water phenomena. Looking specifically, definition of MALT, the mucosal associated lymphoid tissue. The mucosal layer is a major barrier to infection. The mucosal layer serves as a type of barrier between the outside world and the host. It is composed of rapidly replicating array of epithelial cells. The sensing of the external environment can occur via the extensive nervous innervations that, since the cells are avascular in nature. Mucosa provides microbial, biochemical, mechanical, and anatomical barriers to prevent infections. Talking about mucomal plexus, this includes the auditory, respiratory, gastrointestinal, and genitourinary mucosae. There are antimicrobial secretions on the mucosal surface and in the saliva, tears, and cervical mucus, which contain iron-binding immunoglobulins to inhibit microbial growth. And viruses can break down the oral and gut mucosal barriers, such as a herpes simplex virus. The mucosal plexus is a dense network that is not actually located in the mucosa, but is located just underneath the blood vessel network at the border between the mucosa and the submucosa. The mucosal lymphatic plexus forms a continuous network along the entire mucosal surface within the nose, mouth, and throat mucosa, transitioning without interruption. What is mucus specifically? It's required to maintain gut barrier integrity, can be found in almost all epithelial surfaces or in tube-like structures. 90 to 95% water, 1 to 2% lipids, proteins, and electrolytes. Mucins are within mucus and are proteins that contribute to major structural and functional components of the viscoelastic gel. Transmembranous mucins support protection and are involved in host microbiome interactions. There's speculation that the microbiome feeds on the actual mucins. Gel-forming mucins have capacity to migrate to other portions of the digestive tract to bind with water and make a net-like protective structure. What are mucins? The glycan repertoire of mucins can select for distinct mucosa-associated bacteria that are able to bind or degrade specific mucin glycans as a nutrient source. The intestinal mucus layer is at the crucial interface between host and microbes. Its breakdown leads to gut bacterial encroachment that can eventually cause inflammation and infection. Given that the small intestine is a metabolically active organ that is specialized in nutrient uptake, a loose mucin network may facilitate the uptake of dietary molecules across the epithelial border. Despite being a barrier against the gut microbiota, intestinal mucus requires the presence of bacteria to develop its full functionality. Bacterial mucin degradation that exceeds mucus renewal by the host is an evident factor that leads to barrier dysfunction and likely contributes to diseases. The small intestine mucus. In the small intestine, the mucus is almost porous, allowing it to interact with bacteria. Mucus thickness varies along the digestive tract and does not contact the intestinal epithelial cells except at the tips of the villi. Animal data in mice indicates that mucus is twice as thick in the duodenum as in the jejunum and ileum. Certain bacteria require the mucus to survive, and the wrong kind of bacterial overgrowth will devour the mucus layers and lead to tissue degeneration. Going back to the image inside the small intestine, we have the microvilli again, and so looking at the tips of the microvilli, which are here at the top, we could imagine that there is an environment in which the mucus and the microbiome are interacting with the microvilli. Then you have the support of the lymphatic system, the fresh blood coming in, and the venous blood bringing blood out. So the whole process is critical in nutrient absorption and detoxification. There's a real alchemy that happens at this level. Looking at the mucus of the large intestine, it has an inner and an outer layer. The inner lining is attached to the epithelium and is not as porous to larger bacteria. The outer layer is 4 times as thick, acting as a net-like structure, and its propensity relies on the health of the host and not as much from bacterial contact. Outer layer is non-attached, and it is porous to smaller commensal bacteria. The colonic bacteria form an active internal bioreactor that produces a tremendous number of metabolites, including vitamins and short-chain fatty acids, which influence host physiology, mostly in a beneficial way. The Western diet, a diet with high content of saturated fatty acids and sucrose, but only little dietary fiber, led to increased penetrability of the colonic mucus layer. And then that goes into a lot of the osis and itis issues like irritable bowel syndrome and just degenerative bowel issues. The structure of the mucus layer is affected by the gut microbiota. Gut bacteria are separated from the host epithelium by the intestinal mucus layer, which is fortified with host defense molecules, thereby affecting mucus strength and mucin glycan structure. This can in return affect gut microbiota composition, as specific gut bacteria can bind and metabolize mucin glycans as an energy source. Degradation of glycans leads to the production of microbial metabolites, which not only affect goblet cell differentiation, but also the abundance of other microbial species. This image here, we can see an example. Here we've got the gut microbiota represented in these small substances. Then we have the mucus layer in blue, and the epithelial cells here at the bottom. So the microbiota feed off of the mucin glycans, and depending on the whole area is dependent on the quality of microbiome in the area. the exchange of nutrients is dependent on the microbiome, and one will affect the other. So it's easy to get a population or a composition of the wrong kind of bacteria in an area if you don't have the proper mucins available in the mucus layer. This image here, the image on the bottom, is still the microvilli and produced in the small intestine, and the image on the top here is an example of the large intestine and its various layers interacting with the mucosa, interacting with submucosa and the muscular layers, which allows the proper contraction and peristalsis effect. According to recent studies, the mucus layer not only acts as an important factor for protecting the host against microbial invaders, but also contributes to the mutualism between the host and microbes. Many diseases are associated with the alteration of the mucus layer thickness, but it is difficult to identify whether this effect is a cause or a consequence of the disease. Additionally, recent evidence suggests that specific gut microbes contribute to the regulation of the mucus barrier and eventually intestinal and host health. A summary of mucus. The intestinal mucus layer has a primary role in intestinal protection against mechanical, chemical, and biological attacks and contributes to the maintenance of intestinal homeostasis. It creates a coat that covers the intestinal cells, protecting them from contact with external and toxic substances, digestive enzymes, and bacteria. The important protective function of mucus stands out from its continuous secretion into the GI tract, approximately 10 liters of mucus per day. Looking at gut microbiota and terrain, the gut microbiota strongly contributes to modulate the intestinal mucus layer. Gut microbiota are required to activate specific enzymes for optimal absorption. The composition of the gut microbiota undergoes a change from the mucosal to the luminal fecal side, as observed in both humans and mice. Luminal and mucosal associated microbiota are different ecosystems with different microbial diversity and composition, as well as metabolic and immunological functions. Intestinal oxygen and nutrient distribution are able to affect the gut microbiota composition of the fecal and mucosal adherent microbiota, suggesting that oxygen can favor or impede the growth of some microorganisms near the epithelial surface. The intestinal mucus layer represents a natural and biological selective habitat for the gut microbiota, in which particular microorganisms called mucus-associated microorganisms can live, thanks to the presence of mucin glycans, which serve as attachment sites for bacteria, promoting their colonization. And this just shows us again that the mucins also feed the beneficial bacteria. So if the mucins are not there, the beneficial bacteria will also not survive. The microbiome diversity is critical. Difference in gut microbiome composition and diversity are shown to be linked to personality traits in the general population. Regarding the immune system, Dr. Still discussed that the opportunistic bacteria behave similarly to buzzards and that they circle around waiting for something to die so that they can feed themselves. Putting it all together and looking at terrain dysfunction, pathogens were once microbes that developed further mechanisms leading to an increased virulence factor. Disease requires that the pathogen overcomes the host's genetic, physical, cellular, microbiological, and biochemical defenses. Microbes are opportunistic in that they will take advantage of the impaired defenses of the host and cause disease. The key to preventing infection is to better understand the microbial pathogenesis and immunology potential of the host. And that's coming from Seffinger. The effects of the microbiome on behavior. Research on the microbiome is indicating that the internal bacterial environment can affect functions such as digestion, metabolism, immune system, growth, and development, and now it also includes human behavior. It's estimated that we have an equal number of cells to bacteria in our bodies, and most of the microbial cells are in our gut. The gut microbiome has been shown to be interacting with the central nervous system. There's also some indication that the dysbiosis of the gut microbiome is connected to psychiatric and neurological disorders. To summarize the microbiome within the gut has been shown to influence cognition, behavior, and neural development. Modifications in the microbiome may be associated with psychiatric and neurological conditions such as anxiety, depression, delirium, and psychosis. There are several neuroactive and immunomodular compounds that are produced by bacteria, which play a role in brain function. These include histamine, serotonin, dopamine, and acetylcholine. The vagus nerve operates as a messenger for connecting the bacteria signaling to the brain to the neuroenteric axis. The result of inadequate gut microflora can lead to an abnormal behavior as well as neuroendocrine responses that will in turn reshape the composition of the microbiota, which causes a negative feedback loop associated with many chronic digestive issues. Dr. Still's view of bacteria. Different kinds thrive on different kinds of tissue. The germs are not the real cause of the disease, so that the kind of bacteria developing will depend on the kind of tissue devitalized. Two people will nurse the same disease, inhale the same germs. One will contract the disease, the other will not, because in one was the area of lowered vitality, which furnished the suitable home and breeding place for that particular variety of germ. In the other, healthy tissues provided no germ food. A free flow of healthy blood is death to germs. In closing, we're just looking at a summary for lymphokinesis. We want to utilize the anatomy of the central chain to liberate tensegrity imbalances, densities, compactions, restrictions, or any limitations to the expression of the vascular tree. This will correct pressure gradient imbalances and reduce tissue resistance, thereby restoring local optimal lymphokinesis to organs and tissues. We want to liberate the vascular tree, in particular the arterial supply to the cervical spine and cranial base, the heart, pericardium, the diaphragm, the liver, the celiac arterial arcade, superior mesenteric artery, and the left and right iliac arteries. The result can be an opening of detoxification pathways by indirectly addressing not just the superficial lymphatics, but also the deeper lymphatic system. This will help reduce any edema or lymphostasis, as well as sources of hidden inflammation, and enhance beneficial microbiome diversity via food therapy. This concludes part 1, and just an introduction to part 2, if you're interested. The educational goals. This lecture will reveal the role of managing the lymphovascular terrain in order to influence the homeostasis mechanisms by reducing the resistant forces accompanying excessive allostatic load. In addition, there's a focus on the implications of non-injury related general edema and hidden inflammation on the health of the body ecosystem. Topics also include harnessing the connective tissue intelligence and taking into consideration the implications of hidden pressure gradient imbalances, working together with tensegrity forces as they organize around the vascular tree. This lecture also explores the health dynamics as it pertains to immune resiliency, chronic health complaints, and lifestyle accumulated dysfunctions that are increasingly becoming more pervasive and can be rooted in lymphovascular terrain dysfunction. Thank you for your interest in this topic. My contact information is below, and references are to follow.